Good evening. My name is Howard Hu. I'm the Dean of the Dalhousie School of Public Health, a bustling public health and health systems hub at the University of Toronto. And you are a fantastic collection of faculty, students, other scholars, staff, partners, opinion leaders, alumni, donors, and other friends and stakeholders. And you're also very smart and pay attention. You managed to pick out that email about the last-minute change in venue because of the crowd overflow. Not a small feat in this age of email overload. So congratulate yourselves and welcome to the first lecture of the Dean's Leadership Series. This series aims to educate our community and beyond about critically significant issues facing the health of Canadians and stimulate and share ideas on how our society can respond to those challenges. Before we welcome our keynote speaker, President Emeritus of the University of Toronto, Dr. David Naylor, let me share the context of this series with you. First, I'd like to acknowledge many of our special guests tonight, including, and raise your hands here, folks, members of our Dean's Advisory Board. They are here in front. The School Council, which includes all the core faculty. Raise your hands, don't be shy. My Dean's team, mostly sitting in front here. And our campaign cabinet, led by its chair, Paul Dalhousie, and vice chair, Michael Dan. Thank you very much. Also, so you are aware, this lecture is being filmed and will be posted on the Dalhousie School of Public Health website in the coming weeks. So I invite you to visit the Dean's Corner for that video and more. Now, may I kindly ask you to turn off your cell phones at this time to minimize distractions. I left the United States in 2012 to lead Canada's largest public health school for a myriad of reasons, and believe me, they had to be compelling, as I left behind a 22-year career on the faculties of Harvard and the University of Michigan. First, the school's strong partnerships with our health system, including Public Health Ontario, Health Quality Ontario, Cancer Care Ontario, Toronto Public Health, the University of Toronto Hospitals, as well as NGOs and community groups. These partnerships ensure that the school does not function as an ivory tower. We are deeply engaged with these partners and others, enabling us together to have a major impact on the health of, on the health of Torontonians and beyond. Second, I was compelled by the University of Toronto's rich data resources, including the Institute for Clinical Evaluative Sciences, which many of you know was the brainchild of our keynote speaker, Dr. Naylor. Access to vital health information on millions of Canadians accelerates research, and believe me, in my global travels, I know is truly the envy of health researchers worldwide. Third, I was enticed by assets like the Institute for Health Policy, Management, and Evaluation, led by our own Staney Brown, who will be moderating this evening's panel discussion, and the Joint Center for Bioethics, led by Jennifer Gibson, which are international research and policy powerhouses. Finally, and perhaps most importantly, I was drawn to Canada's universal health care system and the promise it holds to integrate public health and health systems. Work by our faculty and high users has been instrumental in advancing this agenda, and our Division of Clinical Public Health, the first of its kind in North America, will provide the vehicle for training providers to work together. Ross Upshur leads that division, a major innovation in public health and health systems education, and you'll hear more from Ross tonight as part of our panel. In 2013, our school became the University of Toronto's first standalone faculty in 15 years. This transition, which was engineered collaboratively with the Faculty of Medicine, and Trevor Young, the Dean of Medicine, is here somewhere. Trevor, are you here? There you are. Thank you. Allowed us to spread our wings as a full partner with medicine and with other U of T faculties. Collectively, we are having a greater impact on health and health systems than ever before. We're also creating collaboratories where our scholars can work with government, communities, NGOs, and the private sector to innovate our way to a more sustainable health system, the very topic of today's lecture. This impact is captured by our position as the top Canadian global university for social sciences and public health, according to U.S. News & World Report in 2015. Globally, we ranked at number 14, but perhaps more importantly, we are number 3 among public health schools located in countries with universal health coverage. To further support our faculty's steep growth trajectory, we launched the Dalalana School of Public Health campaign last year, the first fundraising campaign for a Canadian public health school. So this Dean's Leadership Series is an opportunity for lively discussion that flow into our school's strategy for tackling major health challenges and how collectively we can shape the view of what a healthy individual and a healthy society will look like in the future. It's with this in mind we're delighted to have as our first lecturer David Naylor, with Susan Fitzpatrick, André Picard, Peter Pisters, Leslee Thompson, and Ross Upshur, comprising a superb and diverse panel of health leaders and opinion leaders to spark the discussion. Please read about them in your program. Dr. Naylor, of course, was the chair of the National Advisory Panel on Healthcare Innovation that generated the recent landmark report on strategies for strengthening Canada's health system. He was also the president of the University of Toronto in the fall of 2011 when I was being recruited to Toronto. I was already familiar with Dr. Naylor by his reputation as a global leader in clinical epidemiology and health systems thinking when we first met in his office overlooking King's College Circle. I subsequently became personally acquainted with just how persuasive he could be through a mixture of sheer intellectual power, experience, wit, a seemingly inexhaustible supply of juicy metaphors, and a bit of horse trading thrown in. And now, for a more proper introduction, allow me to present Professor Staney Brown, the director of our Institute for Health Policy Management and Evaluation. Like Dr. Naylor, Staney's a Rhodes Scholar. He also has an impressive global experience and has advised the World Health Organization, banks, software and insurance companies, and healthcare providers in North America, Europe, and Asia. Please welcome Staney Brown.
So thanks, Howard, and thanks to all of you for being here tonight for our first in what I think will be an exciting series of lectures. It gives me a lot of pleasure, I think both from a very professional perspective, but also from a very personal perspective to introduce Dr. David Naylor. I think people can read the bio. They'll see what is a shockingly short précis of a phenomenal career to date. I'll just highlight a few things. David's got an early and I think really kind of star-studded rise, scholarships across clinical disciplines when he's in medicine. He's a Rhodes Scholar. He goes on to be the founding CEO of the Institute for Clinical Evaluative Sciences and Dean of Medicine at the University of Toronto, and then the University of Toronto's president. He's got a long list of awards and honors, and again, could spend a lot of time here talking to you about them. Fellow of the Canadian Academy of Health Sciences, Fellow of the Royal Society of Canada, an Order of Canada, and he's got a long list, an arm's-length list of leadership accomplishments. I won't talk about all these different roles, merely to just highlight once again that he was recently the chair of the Federal Panel on Healthcare Innovation. But I think perhaps what is most impressive about David, in addition to all of this professional activity, what he may regard as his greatest accomplishment is actually his mentorship, scholars, and leaders across our health system. I'm one of the people who's benefited from that. When I was struggling to finish my doctoral work, I sent my work off to a few of the people I really respected the most. I got a response from my father within a couple days. That's to be expected. And it wasn't overwhelmingly disappointed. But I got a response from David just a few days later, which shows just how serious he takes that interaction with students. And it was the type of fundamental and helpful advice that not only made my work better, it actually helped me get it done as well. With that, please join me in welcoming David to the stage.
Thank you very much, Staney, Professor Brown, for that very generous introduction. I'm amazed that after I sent you the email with the comments on your thesis, you were still speaking to me, and I'm really glad that you remember it so favorably. Thank you also, Professor Hu, for inviting me to deliver this inaugural lecture in the Dean's Leadership Series. I'm keenly aware, ladies and gentlemen, that my real role here is to be the setup guy for the outstanding set of panelists that we have. So we're going to fly over lots of terrain this evening at a pretty good clip. And fair warning, I'm not going to read the slides to you. You will read them while I talk around and about them. And that way we can get more done. And in particular, notwithstanding the efforts of the previous Prime Minister's office, the findings of our recent innovation panel have had a fair bit of airtime in the last 6 months. So given that, accordingly, I want to take a somewhat longer view. And let's go back to the future. We'll travel in our customized LHIN, customized for time travel, probably made in Canada, in New Brunswick, by the way. And we're going to go back to 1974, which is the year I entered U of T med school. Don't laugh, be nice. Now, 1974. We have a heavy metal version of a 1960s dance hit. Grand Funk have taken first place on the charts. Richard Nixon is bounced from the White House because of the Watergate scandal. We have Ellie and Foreman in the Rumble in the Jungle. They have that and they disappear into history. And then we had a charismatic prime minister for a change. And that is our current prime minister under Pierre Trudeau's arm. A different time. It's also an exciting year for Canada in healthcare innovation. The Burlington trial of the nurse practitioner was a signpost of the creative energy of a new medical school at McMaster, created, I might add, by reformist refugees from the conservative University of Toronto. In the trial, families were randomized to receive usual care or care by a nurse practitioner in partnership with a family doctor. And the results were staggering. Almost 70% of the GP's work could be delegated safely and effectively, and everyone was happy with the change. The results were soon replicated in many other countries, and faced with this important evidence, how did Canada's healthcare policymakers respond? Well, as the authors feared, if you read the last line of their abstract, existing barriers to adoption were steadfastly maintained. Scaling and spread of the innovation stalled, and 40 years later, data from the Commonwealth Fund showed that Canada was lagging many peer institutions in employing nurse coordinators for primary care. Let's go on to another one. In 1973, the late great Fraser Mustard, he of Determinants of Health and many other fames, was asked by the Ontario government to lead an advisory panel on health human resource planning. Mustard and his colleagues boldly looked upstream at the real problem, and in 1974 proposed a set of 8 sweeping healthcare reforms. Their plan is summarized very telegraphically on the slide. It may sound familiar. In fact, many of the audience will have read last year's excellent report from Ontario's Primary Healthcare Expert Advisory Committee, lead authored by Dr. David Price. It proposes regional patient care groups as a new model of population-based primary health care for Ontario. And yes, it has some fine novel features, but in many ways, it's old wine in new bottles. Now, something else exciting happened in 1974 that many will recall. The Lalonde Report made global waves and established Canada as a thought leader in public health policy. Borrowing from research done in multiple jurisdictions, Canada's Minister of National Health and Welfare made the case that health was more than disease and more than a function of medical care. Other determinants included our biological endowment, environmental factors broadly understood, and what were then called lifestyle choices, terminology that gave the editorial cartoonists lots of fun. Now, there was already evidence that even in countries such as ours with universal healthcare schemes, serious socioeconomic gradients persisted in health status and health outcomes. During the 1980s and 90s, led by a strong Canadian contingent, academics worldwide continued to refine the health determinants model. And that model, as we all know, remains an important toolkit for understanding why some people are healthy and others are not. But not enough attention was paid to practical application of those ideas by academics and, above all, by policymakers. In fact, we still know to address the causes of the causes. The current shameful epidemic of smoking-related lung cancer among the Inuit is a prime example of that. And we have never undertaken the structural reforms that would align incentives in favor of primary prevention or health promotion, let alone upstream with the social determinant strategy, a point to which I'll return near the end of these remarks. So let's pause and take stock of where things sat in the 1970s. Healthcare in America was a mess. Tens of millions without coverage, health-related bankruptcies commonplace, for-profit healthcare plans on the rise, with attendant concerns about cream skimming and care skimping. Not good. Britain's National Health Service, now a high performer, was beset with queuing problems, and parallel private insurance was gaining momentum. Meanwhile, Australia, another high performer today, had just introduced Medibank and was still ironing out the kinks in universal healthcare coverage. Canada was indeed the universal healthcare Camelot of the world. Looking back, however, and weighing how those three big ideas failed to make serious inroads, it's plain that trouble was afoot. Indeed, by the 1990s, many expert observers were becoming concerned that we had inadvertently created a prepayment architecture that seemed purpose-built to resist reform. Private hospitals with blue ribbon boards dedicated to institutional immortality. Private fee-for-service doctors bargaining collectively with provincial governments. Great prescription for gridlock. No integration of budgets. No coherent administrative and governance machinery. And no real accountability or incentives for anything other than service volumes. Now, recognizing that problem, many provinces began organizing healthcare on more of a regional basis, a good idea in theory. But in what has become a recurrent pattern, the execution was half-baked. Doctors and drugs remained outside those regional budgetary envelopes, while health and social services stayed in their silos. Happily, the 1980s also saw some creative experimentation south of the border, most notably the RAND health insurance experiment. This was a unique randomized trial of different payment and cost-sharing modalities that ran over the course of a decade. And you'll see on the screen a key finding, a 25% per capita cost advantage for a nonprofit HMO model, or in modern parlance, an integrated delivery system, as compared to Canadian-style health insurance with silos of service and fee-based payment. As it happens, our friends in the US ignored that evidence for a long time. So unfortunately did Canadians. We were too busy patting ourselves on the back for not being like those silly Americans. And that is a bad habit that has infantilized healthcare discourse in this country for decades and continues sporadically even today, at a time when there is so much to learn from what is happening south of the border. Now, through the nasty 90s, amidst all the budget cuts, there was continued work on integration, on made-in-Canada HMOs. But that stalled rather quickly here in Ontario. Arguments were made repeatedly in favor of the virtues of an integration approach. The idea was that a publicly funded nonprofit integrated model could be the cornerstone for real reform in Canadian healthcare. And as many will know, it was the former chair of the Department of Health Administration, the forerunner to IHPME, who was the thought leader in Canada in that regard, Professor Peggy Leet. Here, in a paper published in 2000, Leet and her co-authors trenchantly set out the failings of Canadian healthcare as it then was. A series of disconnected parts, she wrote, a hodgepodge. Well, ladies and gentlemen, 15 years later, 40 years after 1974 or more, almost exactly the same things could fairly be said about Canada's healthcare arrangements from coast to coast to coast. So let's come back to the question in the title of this talk. Can we innovate our way to a sustainable health system? That was more or less the question put to our federal advisory panel in 2014 by the former federal Minister of Health, the Honorable Rona Ambrose, who was a fabulous interlocutor for the panel throughout our journey. Now, our report was released in July of 2015. As I said, it's been presented and debated many times. Although the report seems to be tagged with my name these days, I want to emphasize this was truly a complete collective effort, one with very substantial stakeholder input and excellent cooperation from provincial and territorial ministries. All the panelists shown on the screen contributed very meaningfully, not least the late and lamented Dr. Cy Frank from Calgary. I think my colleague Neil Fraser from the panel is here, and he would want to join me in acknowledging the panel's enormous debt to a spectacular secretariat in Ottawa. So in brief, what did we hear and read? Many inspiring stories of local creativity, commitment, and innovation in all forms. And many, many expressions of frustration with the status quo. Above all, frustration with the ongoing failure of good ideas and proven innovations to be supported, scaled, and spread. No surprise to any of us who remember 1974. Now, the panel recognized, obviously, that Canada has healthcare systems that are excellent in many places and in many ways. But the totality of evidence and opinions left us in no doubt that we were losing ground, a point underscored by the well-known 2014 Commonwealth Fund report card that has been shown, I think, in many media outlets. It's really sobering. 10th out of 11 countries, and who knows the way the Americans are going, they could pass us in a few years. Below the median on pretty much every measure, and per capita costs substantially higher than those of the United Kingdom and Australia, both of which consistently are rated as stronger performers than Canada. Now, I want to acknowledge that Canada does have excellent healthcare providers. But in the current poorly integrated system, these well-educated and committed professionals often struggle to deliver the consistently high-quality care that Canadians deserve and expect. And many of them also cannot make full use of their knowledge and skills because of regulatory and financial barriers of the type that confounded the adoption of the nurse practitioner. And this is occurring at a time when healthcare everywhere is changing in response to demographic pressures, the revolution in information technology, greater engagement by patients in their own care, and insistence on their autonomy, and of course unprecedented advances in medical science, most notably precision medicine. Many stakeholders on our journey told us that Canada was not well positioned to respond to these forces of change, and we ended up absolutely agreeing with them. I do want to acknowledge that yes, provinces and territories have been working away on important reforms, due credit where it belongs. But their top priority, understandably, has been allocating and reallocating scarce dollars to the delivery of frontline services. I think the hard reality is that many provinces and territories lack catalytic funding, and in some cases a critical mass of expertise to make substantial changes in the way their healthcare systems work. This slide summarizes very concisely where we ended up. Many stakeholders called on the federal government to create an innovation fund, a substantial fund that could be invested to support reforms, not least the implementation, evaluation, and scaling up of positive changes in healthcare delivery. Unlike traditional transfers, or even some of the earmarked funds for health transfers that have flowed in the past designed to abet reform, these funds would not flow on a formulaic basis in our recommendation. Instead, they would flow according to their potential impact in achieving sustainable change. Indeed, while we imagine that provincial concurrence would be crucial to ensure sustainability of those changes, funds could actually be directed to simply coalitions of the willing, committed innovators from varied backgrounds. We also heard and were persuaded by calls for the creation of an arm's-length innovation center. Such a center could ensure the smart and strategic deployment of any new innovation funds, partner in evaluating the effectiveness of new models of care, and draw on the fast-growing field of implementation science to accelerate the scaling up of best practices and policies across the country. So far from creating more bureaucracy, our proposal was to consolidate 3 existing agencies. And yes, those 3 agencies have done some fine work. However, the current situation with federal agencies highlights what I personally believe is a more generalized problem with Canada's innovation landscape. We too often maximize overhead costs and minimize effectiveness by creating and perpetuating subscale boutiques to address important policy matters. Contrast, in this instance, our existing firepower in Ottawa with the combined funding and heft of the U.S. Centers for Medicare and Medicaid Innovation, commonly known as CMI, and its sister agency for health research and quality. And consider the extraordinary flow of innovations in healthcare finance and organization that have been catalyzed, not just by the Obamacare payment reforms, but by CMI's agile and expert work in implementation and evaluation. Its signature evaluations, as it calls them, of new modes of delivery are at once practical and so rigorous that they routinely pass peer review for top journals like JAMA. Weigh those realities, and then ask yourself how we're supposed to break Canada's long-standing health policy gridlock with the same old agencies and the same old federal-provincial funding formula. You know, isn't one definition of insanity doing the same thing over and over and over again and expecting different results? Now, time does not permit me to review our findings and recommendations across the 5 areas shown on the slide, or to get into our thoughts on consensus building and tax reforms. In some respects, apart from the section on precision medicine and the pro-poor tax credit for out-of-pocket medical expenses in the report, much of the rest of it, unsurprisingly, is a careful distillation and synthesis of ideas and recommendations of many previous panels. Now, where's the report today? Perhaps I can go with some of the things we said and what one might say is happening in the system and in the policy realm. Let me begin by emphasizing, ladies and gentlemen, that I'm delighted by the approach taken by our new federal health minister. Not only her dealings with the provinces and territories, but how they are responding to Ottawa now is refreshing. I'm sure you share my pride in the fact that Dr. Philpott has a Master's of Public Health from the DLSPH School. And I think some very sensible priorities are being set at the FPT table. However, to repeat, I continue to worry that if we cannot make the fundamental changes urgently needed in Canada's healthcare systems with existing mechanisms, to continue to try to make those changes by investing more through the same channels in the same ways is not prudent or rational. Now, as my allotted time winds down, I want to come back to the title of this talk, because I deliberately substituted health for healthcare. And it is maddening, ironic, frustrating that Canada, the country that led the world in thinking about the determinants of health, is an implementation laggard today, even in basic health promotion. Of course, the US still has a patchwork quasi-system with many flaws. But the Obamacare reforms targeting primary prevention and health promotion are being implemented and assessed, and those programs and incentives appear to be driving real positive change. Meanwhile, as you might expect, the big nonprofit integrated delivery systems are taking population health very seriously. Why? Well, not just because, as Dr. Feinberg suggests, it's the right thing to do. They're also doing it because the happiest, healthiest enrollees are likely to consume less health care. Keeping people well or doing primary and secondary prevention makes enormously good economic sense. And so it is that at Kaiser Permanente, one of the top such nonprofit systems, there's a huge push to address health disparities. We believe health is a civil rights issue, they say. And there's more to this than simply lip service on a web page. This is a slide routinely put up by the CEO of Kaiser Permanente, showing how they measure and track their progress in implementing primary and pre-primary preventive measures across various vulnerable minority groups that have traditionally been underserved. This is clear evidence that they are taking things seriously. And I appreciate that some in the audience will argue rightly that it's still too far downstream, it's still in the clinical sphere. I fully agree, especially considering, as mentioned earlier, situations such as substance abuse and nicotine addiction in the far north. But I would wonder, what if 20 years ago, when we already saw those very high smoking rates among the Inuit, what if 20 years ago we'd been pragmatic and used that knowledge to launch a really major outreach and education campaign? Would the Inuit still have the highest lung cancer rates of any population in the world today? Ladies and gentlemen, the reality, no matter how you cut it, is that we've had all kinds of great ideas for a very long time, but we have still lost a lot of ground by failure to scale, failure to adopt, failure to execute. It's certainly the truth that the nature of our federation, we put the fun in dysfunctional, don't we? Our political federation makes it very tough to make up lost ground. But I would say to you that Canada remains a remarkably resilient and adaptable nation, a nation of immigrants, a place of cautious optimism. And so on this multiple choice question in the best Canadian tradition, I will be a cautious optimist, and I'm going to choose C, but you can choose whatever you think is the most appropriate answer. One reason for my optimism is gatherings like this. Canadians care about these issues. There's likely to be an ongoing groundswell for change. But another reason for optimism, as I've shown on the slide, is that expertise and leadership matter. They matter a lot. And by great good fortune, what has come together at this time in this city region is a remarkable concentration of expertise and leadership that's brilliantly positioned to help move Canada towards a more innovative and sustainable health system. We've been blessed with a diverse and dynamic population, generous benefactors, and powerful legacies of excellence across disciplines at the University of Toronto and in the great health-related institutions and community agencies of this city. The leaders, faculty, staff, and students are competitive with the best in the world, and at risk of sounding like an institutional chauvinist or perhaps like an ex-president, may I say that it has been an inspiration in recent years to watch the extraordinary rise of the Delaware School and the exciting transformation of the Institute for Health Policy Management and Evaluation. Together, those academic entities have created a truly important resource for better healthcare and better health here at home and across the world. Thank you again, Mr. Dean and Mr. Director, for your confidence, and ladies and gentlemen, thank you for your kind attention. You want me over there?
Thank you, David. I always find myself agreeing with David at the end of his talks, particularly with that last slide. Look, it's my pleasure right now to welcome our panelists up on the stage. If they could join us on stage now as I do their introductions. First I'll just sort of read out again very short summaries of what are remarkable sets of achievements. So joining us on stage now, André Picard. He's the health columnist of the Globe and Mail. He's got a set again of remarkable recognitions and awards, including the Michener Award for Meritorious Public Service in Journalism, the Centennial Prize of the Pan American Health Organization, honorary doctorates from the University of Manitoba, which is something my parents would have made me respect deeply, and the Ontario Institute of Technology. And perhaps most importantly, in the words of Bayard Rustin, he's someone who speaks truth to power, which is not always easy. Seated beside him is Susan Fitzpatrick. She is the CEO of the Toronto Central LHIN. She was the Associate Deputy Minister, to put it kindly, of getting things done in the ministry for a long time. And having worked with her for years, I'd say someone who is a constant champion of quality, a superb colleague, and a real team player. Beside her is Peter Pisters. I think a nice example that we can actually reverse the brain drain. And of course, we've brought wonderful weather for him for his first winter back in Canada. He's the president and CEO of the University Health Network. He's a remarkably well-regarded and internationally known surgeon. He's been a leader at MD Anderson, among many of other places. Degrees from NYU, Western, and Harvard. And I think as well someone who's leading now UHN on a remarkable journey that I think we all hope we will be successful in, if nothing else because it will raise the standards across the entire province by that. Seated beside him is Leslee Thompson. We're really fortunate to have Leslee. This is, I think, day 3 of your new job. She's the newly minted or newly installed CEO of Accreditation Canada. She was the CEO of Kingston General, and there's a list of leadership roles prior to that across our health system in both the public and the private sector. And having served with her on the Ontario Health Innovation Council, I can tell you that she's someone who's sort of a singular force for innovation regardless of the place where she's working. And beside her is Ross Upshur. Dr. Upshur, I think, is known to an awful lot of people. Carries a list of responsibilities and roles at all times. He's the director of the Collaboratory at Bridgepoint. He's the head of our division of clinical public health. And he's one of the few people who, I forget the line quite, but it can hold opposing views in the mind and not go crazy from doing that at the same time. He's constantly intersectoral and interdisciplinary. He balances his scholarship in a way that few could, and having worked with him, I can tell you that he's a remarkable but also a very humble leader. So please join me again in thanking Dr. Naylor. Welcome our panelists to the stage. And with that, I'm on strict orders to keep everyone to 5 minutes of response. André, can we start with you, please?
Yes, thanks, Steny. This is what a PowerPoint looks like for a print reporter. So it's hard to respond to a speech by someone who's a master of the topic, like Dr. Naylor. So what I want to do instead is just give you some thoughts, and I want to start with a story, because that's what I do, I tell stories. So I don't know if anybody, I see a few people my age here, you might remember these red and white health cards that Ontario had for a long time. So I want to start a story about those. Those were first issued in 1972. In 1995, the Ontario government announced they were going to end those, replace them with plastic cards with a photo to reduce fraud, etc. Then in 2005, they announced again that they were going to phase them out and replace them with a card with a photo. And then in 2015, they once again announced that they're going to phase them out and replace them with a card with a photo. Still no chip in there, but never mind. So what's that story about? Today, by the way, there's about 3 million of these cards still circulating. So we're not doing so well with the plan. So what does this story tell us? To me, it's sort of just an anecdote for how frustrating it is to talk about innovation. You know, we have all this promise, we have all these plans, but we never carry through with them. And that's a very simple one. All we have to do is replace things, like our credit card company does every 3 years. We've had 20 years and we've not managed. Change is so glacial and so frustratingly slow to come. And that's to me, I've been around doing this for about 30 years, that's my greatest frustration. That we have all the solutions out there, including changing the cards, but we just don't implement them. And why is that? You know, and what does it tell us? It tells me that if we can't do something as simple as that, what's the hope for real change and for real innovation? And that doesn't fill me with hope. I'm hopeful about other things, but not that. You know, this whole issue is about scaling up, and it's about doing and following through. We don't do a lot of that. So the question tonight is, you know, are we able to innovate our way to a better healthcare system? And I always have trouble with that question. You know, it's the same question as, is the health system sustainable? It's always asked. And my answer is, well, it depends. How do you define sustainability? How do you define innovation? And that has to be the starting point. And our definition is too often, well, let's just do more of it. That's what sustainability is. We need more money, we need more bodies. And as Dr. Naylor said quite correctly, that's been our long-standing approach to things. When something doesn't work, well, we do more of it. Just as Einstein said, that is insanity, but we do it constantly. There are waits in ER, well, let's throw more bodies in there. That must be the solution, rather than change things at the outtake and the input to avoid the problems. And there are a million of those examples. To me, we have to be careful too of this word innovation because it's tricky. A lot of people think innovation means technological change. Let's have more bells and whistles. And for me, the innovation we need is really culture change. And what do I mean by that? I mean thinking about things differently, not just cautiously doing more of the same, but actually doing things quite remarkably differently. To me, the real shift we need is a move from a sickness care system, which we have, and we do tremendous sickness care, to a healthcare system, where we actually think about health and we think about prevention first and foremost, and not as an afterthought. You know, the system we have today was essentially conceived in the 1950s and 60s, both the delivery system and the insurance system. It was created for the demographics and the culture of the time. What people needed back then was acute care, and they needed physician and hospital care. So we ensured that, and we did it. Today we live in a very different world, but we still have a hospital-centric system designed to deliver acute care when the vast majority of the population needs chronic care. Again, square peg in a round hole. It doesn't work. And you know, 40 years after the Lalonde report, you saw excerpts there from the Lalonde report, 40 years after, prevention and health promotion is still an afterthought. Other countries have taken the Lalonde report, embraced it, implemented it, all the Nordic countries. We still just have it on the shelf. We haven't implemented it. There was a time, not that long ago, it's getting a bit time ago now, but when we actually had departments of health and welfare. We seem to have forgotten the welfare part of the equation, the all-important part. Now we have ministries of sickness care. That's the reality, not even healthcare. And those systems that we have tend to still be designed around the needs of providers and not the needs of patients. We talk again a good game about patient-centered care, but it's not the reality, and we're not structured to do that. Again, you heard in the talk that, you know, we've made tremendous advances in medicine, and that's wonderful. But medicine isn't the be-all and end-all. We have to talk and focus on what Dr. Naylor again talked about, the social determinants of health, preventing people from getting sick. We still die and are sick today of the same things that we were in the 50s and 60s. Heart disease, cancer, COPD, and diabetes is what kills us. And we still have the same causes: poverty, lack of housing, poor nutrition, etc. So we have to change our focus. So, last little thing, I'm over time. How do we change this? What are the barriers to doing this? Everything I've said, nothing is new. So how do we do it? Well, I'm going to leave that to the other experts to answer.
Susan, over to you.
Thanks very much. I'm going to talk about 5 areas that I think would qualify as innovation in the Toronto Central LHIN. I wanted to give a few facts and figures about the Toronto Central LHIN because I think it's interesting in terms of context. The budget for the LHIN is $4.7 billion. $3.8 billion goes to hospital. And the remainder goes to community support, mental health, addiction, CHCs, long-term care, and CCAC. So a huge investment in hospitals. We have about 1.3 million residents that live here, but a significant volume of hospital services to residents that live outside the LHIN. I didn't check today before I came, but I've heard that it could be up to as much as 50% of services from hospitals or to residents outside of our area. We share the City of Toronto with 4 other LHINs, and between 2011 and 2026, that's 15 years, the projected growth for the Toronto Central LHIN population is going to be 35%, and in one area of our geography, the Mid-East Toronto, is being projected at 53%. So we've got to change. Our sustainability plan is a healthier Toronto, positive patient experience, and system sustainability. I think there's 5 critical elements. The first is the organization. We're moving very quickly to establish sub-LHIN regions, and those will be areas in Toronto. We've identified 5 sub-LHIN areas where we're going to start organizing care, services, and providers around that sub-LHIN population. You can see where we would like to be in an end state. To start, we have to take it a step at a time, and we're going to build on the Health Links model to bring all the health service providers in those areas to talk about how we can provide better care to the people in the geographies. I think many of you are familiar. The population of Toronto is very diverse. We have areas of Toronto that have the youngest populations, fastest growing, and those that have a high proportion of seniors. We've got areas of Toronto that have extreme poverty going to extreme wealth, diversity of newcomers to well-established Torontonians. So we have a lot of work to do. And we think by better understanding the needs of our populations and regions, getting down to the neighborhood level, we can customize our approaches to care delivery. It's interesting from a health utilization perspective, each region also differs. For example, the West Toronto area has high rates, the highest rates of hospital use overall, while the Mid-East has high rates of ED use for mental health conditions, growing at 23% since 2010. So those are the types of things that groups of health service providers can look at and try to change. And then when I look at the variation in demographics, and that leads me to my second area of innovation, which is taking a population health approach. I was very pleased to see in the government's discussion paper about strengthening our partnership with Toronto Public Health, which we have an excellent relationship now, the City of Toronto. Our plan really is going into the determinants of health. I think this is an interesting role for the LHINs to get beyond just a funder of healthcare services, but what can we do to look at the social determinants? Many of our community providers do provide housing, jobs, services to go well beyond just health care. So we're committed to seeking out new partnerships. I don't think our partnerships should simply be within the healthcare sector, but well beyond that. My third area of innovation is integration. In the ministry, I worked significantly on integration. The Toronto Central LHIN has one small integrated funding model. It's a stroke integrated project led by Sunnybrook. But I want to innovate the bundled funding approach across the LHIN. This goes to the scale question. We've already seen that the integrated funding projects take a lot of overhead, and they're directed at small populations. They have to scale across the entire LHIN, and we have to have the will to do that. Fourthly, engaging our citizens. I'm going to set up a citizens panel. I think these designs really have to be around what the citizens are telling will work for them. And finally, leveraging what I'm calling an evolving relationship with primary care. It's not a new relationship. We've established strong primary care linkages within this LHIN through our Health Links partnership. I've seen a couple of people in the audience, and that'll be a key game changer for the LHIN in terms of integrating more broadly. So thank you.
Thank you.
Peter.
Well, thank you. Hopefully this is on. Great. I suspect that perhaps the way that I can best contribute to this dialogue is just to reflect on some of my observations on returning to Canada, re-entering the system, and comparing and contrasting that to the last 5 years during my time in Houston when I saw much of the evolution of change under the Affordable Care Act. And as I come back to Canada, I'm thrilled to see the unbelievable sites of clinical excellence that exist here. The incredible clinical miracles that happen every day in our hospitals, and the passion with which the providers are organized around the individual disease sites that we have, for example, at UHN. I also see, to my surprise, things that I saw as a medical student, such as we still have ALC patients. And I see that in an extraordinary evolution at UHN, where in essence, Today we have about 150 ALC patients, and it could be easily stated that we are running an institution within the institution. And that for a variety of different reasons that are multifactorial and best understood by many in the room, we still haven't solved that problem. And in a time when we've got patients who are sitting on stretchers in our emergency room, that's not good utilization of assets that we've all contributed to as taxpayers. I also see, as I make new friends, renew old friendships, and connect with neighbors and colleagues, that when I talk to the average person on the street who's not connected with our industry, they remain remarkably satisfied with the system. And to my surprise, perhaps as an insider, they don't see a lot of the things that have brought many of us here tonight together to discuss. And those people who do read a little bit more, who follow André's writings, understand that we are sitting at number 10, and those people who've been following what's going on in the U.S., as David pointed out, really should appreciate the fact that we could be bypassed very soon on the basis of the tremendous transformation that's occurring south of the border. I think that when I look at what has unleashed a lot of that transformation, it really has resulted from federal oversight over healthcare in the U.S. The work that Dr. Naylor described from CMI, other work from other agencies like Picard that have really put structure and over $1 billion of investment in controlled studies that have looked at innovative approaches and changes to the delivery system. And really looking at significant changes in health policy to change how markets function in the U.S. and to unleash really incredible change. In the last 5 years of my time at MD Anderson, I had an executive role where I was responsible for some of our regional operations. And in that context, a lot of the work that I did was building out collaborative relationships with health systems in our market and small and medium-sized systems across the U.S. And as I watched the changes occurring, you could see change happening in increments of 6 weeks. I would go back to our executive team and I would say, you have no idea what's going on. These primary care practices are just being bought up left and right. And big health systems are putting in electronic medical record. They're doing so, they're taking over back office function for primary care practices, and they're doing so in exchange for quality metrics and outcomes data. And those systems in turn are organizing themselves around the chronic conditions that are driving patients into the emergency room and really accounting for a substantial amount of the cost. And then as you went to visit a health system, you went to their executive offices, and they would take you on a tour where you would see an entire floor of people who were focused on the heart failure patients that they were responsible for. They were getting data feeds from Bluetooth-enabled scales. A nurse practitioner was calling patients in their homes and saying, your weight has gone up 3 days in a row. Why don't you come in and see somebody? Or in some cases, why don't we send somebody out to see you in your home? Have you got your Lasix? That's where we need to be moving, upstream in managing chronic conditions in the home. All of that was really unleashed by federal legislation that changes the working environment for the provider base. And absent the political will that David alluded to, and absent rational application of policy, it will be extraordinarily difficult to engineer the change that we need to make. I would also point out something that's obvious to everybody in the room, something that I talk with our board about all the time, and that is that the clock is ticking. We have longer life expectancy, we have an aging baby boom, we have the trend line for drugs and devices, new cancer therapies that can cost, with combinations of drugs, millions of dollars per patient, new devices that are being brought out all the time. Who's going to pay for all this? In Ontario, we've got a shrinking tax base, and we've got substantial non-sovereign debt, which is the largest in the world. When you put all those factors together, we need to move quickly. And we don't have time, in my view, to rearrange deck chairs and to make small micro pilots, we need to proceed with substantial change in order to re-engineer the system on the timeline that we're working against. As a society, we're exposed to massive tail risk. When you look at the magnitude of the risk that we are actually going to be passing on to our children, because right now we're charging up a lot on their Visa card, and we're about ready to hand it over to them with a system that doesn't meet our needs as patients, nor their future needs also.
Great. Thanks, Peter. Leslie.
Thank you. To me, innovation is very much a team sport, and it's one that requires a lot of specialized skills and training and practice and coaching and strategy. And for most of you, probably when you think about the sports analogy, you're thinking about a game like soccer, baseball, football. How many people would be thinking that kind of thing as I talk? Well, for the majority of the people out there, 2.5 times the numbers of people that watch sports, there's something called League of Nations. And the League of Legends. And there's also a League of Nations. But the League of Legends is the esports phenomenon that now at one viewing of the final game had 17 million viewers in the final round of League of Legends. It's an e-gaming phenomenon. It is eclipsing the way people have played video games, the way people are engaging in sports, and the relationship that they have with something that they've known for a long time. And while we've heard a lot about innovation here today, I think that, and there's some great examples, as David has also given, but I really believe that we are playing it, even our current innovation with yesterday's rules, equipment, players, and even coaches. People who know how to win the game and who are actually really good at it at one point, but we're keeping playing it while the rest of the world has moved on and ushered in a new era, where the old rules don't apply because there really isn't a rule book yet. And healthcare continues to pride itself on having a great buggy and skilled special buggy drivers, while everyone else is traveling in driverless cars. And that's how big the innovation gap that we're experiencing right here and right now. And when you look and follow what just happened in Davos, the World Economic Forum, the whole focus was on the 4th industrial revolution. We haven't even kind of caught on in healthcare to the 3rd one, the beginning of the 3rd one, and it's already over. And the 3rd industrial revolution was around the very simple digitalization of digital technology in terms of advancing society and practices. And we haven't got there yet, and the rest of the world has moved on. And the characteristics of that and the shift, the velocity, the scope, and the systems impact there's no historical precedent for that. And this is kind of forces of change in the world around us that are going at an exponential pace and not at any linear one. And it's disrupting almost every industry, every country. And we can, in healthcare, keep trying to put these little, put a coat around us to protect the way we are doing things, because we truly believe deeply that we're doing well, we're doing the right thing, and that the rest is just going to pass. But while there is going to be a requirement for substantially different leadership and capabilities going forward, I think the basic premise of, even as we enter the 4th industrial revolution, stays the same. You've got to really know your customers, your stakeholders, the people you serve. You need to be expressively, you need to absolutely know your why. I think we've lost the why in a lot of what we are doing, which is why we can have a lot of incremental, sporadic innovation, but we're not coalescing around the deep kind of results and perspectives. So what does it really take to innovate in a way that has impact across populations and geographies, perspectives, and politics? In order to have impact, because innovation without impact is a complete waste of time, energy, and resources, and those are all in short supply. There's lots of individual success stories There are projects like those from the Canadian Foundation of Healthcare Improvement that I had the privilege of chairing, of taking a single intervention around reducing the use of antipsychotics in a long-term care facility in one area that now we've learned the implementation science spreading and scaling at 17 different organizations right across the country with teams that is making an enormous difference by systematically moving change forward. The other example, and it's one that I'm literally learning about right now, is even with my new role as Accreditation Canada, we have a subsidiary called Accreditation Europe. And as part of our international work, we're in 22 countries, but we've got a major project with the European Union. And this project involves 28 member states. And what they've done is they've targeted low prevalence and complex disease patients who couldn't find health providers in their states, but they had a lot of knowledge about what they were doing. And they actually brought the patients. They brought the patients together first, and across these 28 member states with providers, legislators, and we, as Accreditation Europe, are working on the development of the standards for these practices and protocols to advance the care and for these populations. And it's a remarkable initiative that was driven by very unmet patient needs, bringing together the typical unlikely partners and driving through. We're involved right now in terms of the evaluation of the project as well. And this is not something that costs a lot of money. What it takes is will. And I think that that's probably the big ingredient that we're actually missing. I agree with David Naylor about the leadership being really critical, rigorous application of evidence and evaluation learnings, patient and family engagement. But I don't actually think we need a lot of money, new money. $1 billion would be very good, but I actually think we've got a lot of opportunity to do a lot of changes, to make different choices with the money that has already been entrusted to us. When I think about where I'm going now with Accreditation Canada, in my new role, I'm already thinking around what's going to disrupt us, what's going to put us out of business, not to protect the way which we're doing things, but to actually think, as I learned at one of the most innovative companies in the world, Medtronic, thinking about just how your world would be completely different if your technology and your intervention was obsolete. And what do you need to do to continually drive more and more value for the clients and the customers that you served? So innovation is absolutely a team sport. It involves I love the notion of collaboratories. I want to learn more about them. And the game is fast. Patients and the public are no longer on the sidelines or on the bench. They're in every play, side by side. And we don't have time to study and restudy all the possibilities in the play. We can't put everything on pause to do a pilot project. And we can't stop even when we don't win. We have to keep playing because that practice builds resilience, speed, agility, and some smarts that we then need to channel into driving the health of our communities. And I would actually like to take the position that we hear a lot about all the outside forces that stand in the way and that cause the problems that we have. And I'd like to say that I just don't buy that. I think we're all too quick to say that everything and everyone around us needs to do all the work. I think that we have the power to innovate and thrive in the new world. I think the biggest shift that needs to happen is a mind shift. And I would say my answer to the question that you posed, David, at the end of your talk, of are we able to innovate the way to a health system? My answer would not be A, B, or C. It would be D, and it would be an unequivocal yes, we can and we will.
Great. Ross?
Thank you. It's a real honor and pleasure to be here, and I look out and I see so many friends and colleagues who probably could be much wiser and more informative than I am. And like our estimable moderator tonight, I owe our keynote a debt of gratitude, who also provided me several pages of comments on my thesis at one time, and actually stood up for me in my defense when things were getting a little rocky. So just to remind him of that. So I'm going to take an uncharacteristic for me upbeat approach today. Typically, most people would say I make Eeyore look happy and Schopenhauer look friendly. But today I feel a little bit, it must be the spring in the air that's got me upbeat. I want to speak to a couple of issues, and I'm going to pick up on a lot of what people have said already. We've already heard that we don't have a healthcare system. It's not about health, it's about measuring disease. There's nothing systematic about it. In fact, it's a poorly coordinated set of scrambled services. And the great German philosopher Immanuel Kant said, "By a system, I understand the unity of the manifold molds of knowledge under one idea." And I think we've lost sight of what that idea might be for healthcare and health systems. So there's nothing that holds it together. And as a proud family physician working for 30 years, on the front line, if I come to speak about the front line experience of the poor coordinated services, of the problems that people, particularly older adults with multimorbidity, face, it would be too depressing and it would be sad. And we would be in the position where we thought there's no way we can innovate our way out of this. But we do have a big problem there, and it's a simultaneity problem. On the one hand, we have an urgent need, as pointed out, to respond to an aging demographic. That requires both changes to the way we think about, understand the measurement of health status, the kind of clinical skills that we use and the tools that we use to deal with this at the individual and at the population level. At the same time, we've got a large bolus of people with all of the risk factors coming up, and we have a huge prevention agenda. So how do we bring these two issues together? Well, this is where the upbeat comes from. So we missed an opportunity in 2014 to celebrate two landmark reports in the history of Canadian healthcare. Professor Naylor had already highlighted the Lalonde report, but there was also the Hall report in 1964. And everybody remembers that, and we should have celebrated that, but I think we were too busy with Franklin's ships at the time, not to be editorial. But there was a companion report about health professions education. And at that time, and this is speaking to where I think we need to go in the future, there was a lamentation that those who were involved in population health, public health, or schools of hygiene had become more administrative, and they'd lost their kind of clinical roots. And clinicians had kind of wandered away from their need to understand the broader system features and population health and broader prevention. That was in 1964, and they argued and then for a greater way of bringing these two spheres together. And that's what we're trying to do now at the Dalla School of Public Health in the Division of Clinical Public Health. And this is what makes me excited. It's not me, I'm too old, I've done it, but it's the students that I see. It's the residents that are coming through that are concerned about equity, social justice, the social determinants, and they want skills to be able to go out there and mix up with that population. They're tired of seeing discontinuities of care. They're frustrated and they want change. And the beauty is that at the University of Toronto, we have all of the assets. I look at the room of all the people that I know and all of their skills and all of their abilities. So the university can play that catalytic role of bringing people into a common space to start the discussion, to reformulate the ideas. And I'm just going to end on 2 points. One is about the experience of clinical public health. When you say, people said, Ross, what is clinical public health? That's an oxymoron if I've ever heard one. Clinicians see one patient at a time. We do clinical work, and public health we don't do with individuals. We're out here dealing with the social determinants. Why would you create something like that? So one was, I think we need it. When this school and the faculty became its own faculty, apart from the Faculty of Medicine, we needed some glue, something that kept us together there. But it also provided a challenge. All of a sudden, my first faculty meetings were remarkable. Everybody sat there with their arms folded, glowering at me. What are we doing here, Upshur? We're clinicians, we're public health people. And over 2 years, I must say, having conversations and having people talking to each other and sharing their solutions and their problems is a way of moving things forward. And then we dropped people in from the Joint Center for Bioethics, and we got some anthropologists, and now we've got a rich kind of stew of polyglot disciplines and professions all talking to each other that all share the same problems and all want to find optimal solutions. And the university is that brilliant place where we can at least advance the scholarship and the ideas to move things forward. I am not Pollyanna optimist enough to say that we're going to affect systems change in a very short order. I've tried to do clinical innovations over the last 15 years, and it's hard work at the coalface, but we can get there. And I just want to say one thing, and it's kind of through some of the reports, and I've kind of trailed Professor Naylor around because I was one of the early graduate students at ISIS, and then after the SARS report, I was trying to fix things in infectious disease control, and then he was our dean and president. But one of the reports he didn't talk about was the Lancet Commission on Health Professions Education in the 21st Century, which says that the highest order goal and priority is to provide the 21st century health professional with skills at the population and the clinical level. Not seeing any opposition between this anymore. Stop the siloed bickering about whose turf you're on, and also the very important need to move towards team-based models of care. And I think with the university, we can start to do that sort of thing. If we can't change things in the field now, at least we can equip the next generation of healthcare professionals and practitioners with the sort of skills they're going to need to affect the, it's nice to talk about population health models. Who has the skills to actually understand population health? Where do they get that from? They get that from schools of public health, but we need to be working with our colleagues in faculties of medicine and faculties of nursing and pharmacy and the allied health professions so they have those skills too. And I'm going to end on one note. So several years ago, we started to try to use ISIS data to think about the system as a system, to move it into a dynamic form. So if you think of parts and wholes, there's things that are driving what's happening, and you can sort of see signals of when things surge up and surge down in terms of health services utilization. Then you can sort of go outside of that and say, what are the drivers outside that are making these things happen? And with another brilliant recruit of Professor Naylor is Mohammed Mamdani. We used to sit down and think, what can we do with this data? How can we connect it all together? And one day we stumbled upon a New York Times report about Walmart. And Walmart, so my goal is to get a spy into Walmart's data center because they barcode absolutely everything and they're linked into all the data sets. It's true real-time big data at the work. So if they see a hurricane marshaling off the coast of Florida, they're already got their trucks filled with everything that's needed, beer, batteries, and Pop-Tarts. They know from... And they know this from historical records and short-term forecasting. They're not trying to generalize for all time and place. They know what's needed. They know the right thing for the right market at the right time. Now, if you ask the CEO of Walmart how many bottles of Listerine that they have in Chattanooga, he can give you that answer. If I ask Peter, who's the CEO of a hospital, how many boxes of Kleenex he has in his hospital, do you know? No. So the other thing is, as a clinician who wants to manage a population, at the end of a week, I would like to know how many X's or Y's or Z's have I seen? How many have my colleagues seen? Is there something going on in the community that we don't know about? How many of my diabetics have I not seen? What's the denominator? What have I seen? What have I not seen? So if we're going to go all in for big data, let's make it real time. Let's make it responsive, let's make it useful, let's put it in the hands of clinicians and policymakers and planners, and let's make it accurate. And the bigger challenge is how do we actually get the appropriate calibration of the measures to the phenomena of the healthcare system that we're actually seeing. So we reformulate what we're measuring, and it's accurate and reflective, and it leads us to the goals that we want. So I think we can get there. It's going to take a lot of work. It's going to take somebody to bribe somebody in the Walmart data center so we can get their proprietary software. But I think it's all there. It would be nice if ISIS data was there daily, not at 1 year after. And I think the university is the actual engine of change, and the faculty, not just at the Dalai Lama School, but across the university, because we can reach out to engineers, software people, computer people. I'm a thoroughgoing geek. I love people who love to know and love to learn and love to experiment with ideas, and there is no richer or greater environment than what we have here at the University of Toronto. So let's work together, let's innovate, let's not give up. I'm going to be really optimistic for a change, and then I'll go home and revert to my usual pessimistic, dark-sided self. And I'll close there, and thank you for your time and attention.
So it's my job now to start to probe a little bit on what's been said. So the one of the big ideas we talked about tonight is this idea that we shift upstream. We take some of what we're doing now and we put it in a place that it's actually going to make sure the future looks a lot better. So everyone agrees about the ideas now. You almost never walk into a room and have to re-justify this idea of moving upstream of dealing with population health. And you got an array of people on a stage, all of whom are leaders, agreeing with this as well. So the ideas and the actors line up. But every time we get down to talking about this, the institutions take over and we get into zero-sum territory. And Ross, you and I both know this. We edited a little journal a while ago that talked about public health and primary coming together. And a few thoughtful, forward-looking people said, great idea. And everyone else said, the worst thing that could happen to public health or the worst thing that could happen to primary care. So how do you get beyond the zero-sum game other than the slow socialization you're talking about? Peter, you looked at me, that's the bravest
I
thing.
think the CRISPR technology with gene editing, we just know.
Okay, Peter?
I think we need to get ourselves off the fee-for-service architecture of the whole system, and we need to be moving towards payment for outcomes. The challenge in the system right now, to use a diabetic example, is that if anyone in the room comes to see me as a physician with suspected diabetes, I have two obligations: make the diagnosis and prescribe insulin. At that moment, a transaction occurs, and the whole system is transactionally based. I have no interest, nor are there any incentives aligned in making sure that I protect you against the complications of diabetes. That's actually what you care about. That's what society cares about. We want to make sure that you don't get retinopathy, you don't end up with an amputation, and you don't have a stroke or heart disease. But there are no incentives aligned in a transactional system. And what you then have is an aggregation of providers who are oriented to make sure that transactions occur. That's what happens in that kind of system. We need to move rapidly to payment for outcomes and put providers at risk and accountable for those outcomes. Bring providers together, not just acute care, but the primary care and acute care providers together in one group accountable for the health outcomes of the population, and pay for outcomes, not for volume, not for procedures.
Great, thanks. David?
Please.
Go ahead, Susan.
One thing I would just add is I think about 4 million Ontarians have access to team-based primary care, and I think that access to team-based care has to increase significantly. I think it should be invested in, and I think, you know, part of the analysis is where are the populations that most need it and not accessing it.
David?
I just want to comment briefly on this diabetes and primary care theme that Peter and Susan have raised. So if you're a capitated physician, it used to be, I think Susan changed this, that if you flagged a patient as having diabetes as a diagnosis, you got a bonus. So, surprise, we had an epidemic of diabetes in Ontario. It wasn't about epidemiology, it was about the epidemiology of billing behavior, actually. And the point here that Peter was making is, if you create a piecework incentive system, you turn physicians into pushcart vendors. And there are no incentives for us to be stewards of resources. Amazingly, huge numbers of physicians are careful stewards of resources because of their idealism and professionalism. But boy, the incentives are all misaligned. So I believe that if the incentives were improved, and I'll come back to another area, you could actually find there's a lot more money in the system. A simple one, 20 years ago, I made the mistake of proposing publicly that post-acute home care budgets should be held by hospitals. Cam Jackson, the then minister, called me on the carpet to give me grief for doing this heretical thing because the CCAC precursors were all up in arms. But I stand by that 20 years later. If we'd done that, we'd have a lot better system. CCACs are now reporting to the LHIN. My vote, Susan, you want to integrate? The hospital should be on a budgetary teeter-totter with the CCACs because post-acute home care is a huge cost saving for the hospitals, and this should be not a zero-sum game, but a win-win outcome. Time and again, we've seen these things are possible. We have not moved in these directions. I'm actually somewhat optimistic, Leslie, by the way, you could have picked B because it's the same as what you said, but so you failed the multiple choice test, but I am somewhat optimistic. But I think we have to be realistic here, folks. The realistic view is these changes will only happen if we keep pushing, not only from the broader public standpoint, but the sort of remarkable people in this room who have some clout, who understand the system, to raise their voices and say, let's keep going. We know enough. We actually know what we need to do. Let's just get on with it. And you know, my overwhelming sense listening to the panelists is all of us agree. We know enough. We have a good sense of what we need to do. And it would be lovely for Canadians to get over themselves and just get on with doing it.
Leslie?
I'm still the optimist because I do believe it is in our hands, but I would say that there's two forces that we need that would be really important to address to get at your question, and they're transparency and accountability. And I think transparency is absolutely key, and transparency in a way that it allows us to, we talk a lot about health literacy. I think it's not just about patients and the public health literacy. I actually think there's a whole lot of people in the healthcare system that have no clue how it works, or really are invested in figuring out how to actually change it. So the kinds of conversations that need to happen, I think, are vital. And the other, on the accountability side, that goes with the transparency, I've certainly been thinking a lot, and I hear a lot from people already in my new role. One of the reasons why I'm so excited about Accreditation Canada and its potential role in the transformation of the system is that right now we accredit 1,100 organizations across Canada: acute care, home care, primary care, everybody, regional health systems, all of those. But you can actually be, I did my research when I was interviewing for the job, you can be exemplary and tick all the boxes on process and have some of the worst outcomes of patients that are posted on the website. And that's not okay. It's not okay to be great on process and meet all the standards, but be lousy on outcomes. So the whole link of accreditation and standards and outcomes is complex, but one of the first things that I've done is opened up a Toronto office. We are in with Kai, and we're going to start working around linking standards and outcomes and start having the conversations, the transparency around some of those connections, because I do believe that will play a role in helping to drive the innovative solutions to get us where we need to go.
Thanks, Leslie. David, back to you.
Leslie, that's a great idea. You'll need a flak jacket, and you also better get a great set of statisticians to do meticulous risk adjustment, because many misadventures have happened on that front, but I'm with you. And if you want someone to critically appraise some of the early analyses, including the SAS output, send it to me, because I've seen a lot of very bad risk-adjusted outcomes reported, including some on my watch at ISIS.
Yeah.
Ross?
But I'm counting on you, and everyone can tweet it out that we've got David signed up for some helping to help me and help us be successful. Thank you.
My question or comment there is nice to be outcome driven, but in an era of increasing multimorbidity, what are the outcomes we're actually striving for? And so again, it's this calibration of how we connect with what patients want as outcomes, and what, it's not so you're a heart failure patient, you get a good heart failure outcome, but 96% of people with heart failure are multimorbid. They might be more worried about their knees or actually making it to their granddaughter's wedding. So we need very, very careful thought about what those outcomes are, and then the methods and metrics and statistics to actually calibrate to those, so that we're actually measuring and tracking and getting the right things.
I'll just remind the panelists, I diligently made a whole number of questions while you were talking, and yet you're working off of one. David?
Just to Ross, I'd say, I'm published in that area too, and I get it. But with heart failure, which has the same mortality as many forms of cancer, there actually is a certain outcome that's a bit final that tends to be the top of the patient's list, and I suspect that's the one that Leslie is interested in, and me too.
Yes, but out of respect for we are in an academic environment, and this is really important to kind of focus on getting some things right and evidence, and all of that is highly important, but we've got to marry evidence, experience, and actually keep trying to push the envelope. If we try and perfect everything, we are not going to get, we're not going to unlock the opportunity we're not going to unlock change. And so I think we could have another whole debate on this. Maybe that's another topic, but we've got to marry the best of theory and evidence with experience and being able to impact on the lives of patients and families today. They can't wait for the 10-year randomized control trial for figuring out whether or not people are making a connection with washing their hands and reducing infections. We know some of these things.
André, you've still got your mic in your hand. Are you looking to get in on this?
Not necessarily if you have other questions.
No, please go ahead.
No, I would just say my observation from seeing this is that one of the big problems is because we have such a disjointed system, the benefits of doing something good rarely accrue to the institution or the person who does it, so there's a lack of incentive to change. If a hospital empties their ALC beds, which would be a great thing for those patients, they're going to get patients that are more costly, require more nursing. They're essentially going to be punished for doing the right thing. And there's 1,000 of those things that happen every day. So it's the misaligning of priorities, and the patient need doesn't really get considered. The other one about change, I think, is I used to, for a long time, was very critical of politicians for not leading. Oh, why don't the politicians get in there and lead? And I one day had an epiphany that essentially our politicians lead from behind. They'll make whatever change the public wants. And the Canadian public is really, far too tolerant of mediocrity. And, we have this notion, our health system's free, so it's okay if I wait 8 hours, or it's free, so I guess I could wait a few months more for my hip. And I think the public has to speak up and be more demanding. And we just don't know how much better care is in other countries and how much cheaper it is. And we have to inform ourselves, and we have to be shit disturbers more often.
So let me pick up a little bit on that, and we could reframe maybe shit disturbers as leadership just for a second. So it's been constant through what people have said tonight, right? There's this issue of we need people who are going to do this. Everyone's positive answer, if they had one, depended very much on the people who would not only be reflecting what the public wants, but also leading that in some ways. So how do we get a generation of leaders who don't immediately reframe things as zero-sum games, who don't immediately align behind the institution, and to pick up on some of the language that's been talked about here, really are willing to take the responsibility for the types of outcomes that require us to lose our fetish for control that always takes us back to a process measure or some little intermediate step? How do we get that type of leadership in the system broadly distributed at scale?
We get out of the way. Because I think I mean that with all seriousness, I think that there is far too much of, the reason why we're not getting a lot of the breakthrough is because we are creating the barriers. We as the leaders are creating those barriers and the conditions for people to respond to how we're working. And I believe, and when I look at some of the innovations around the world, what's happened, it's not by the people who have the 30 years experience and necessarily the experts in very, very specialized areas. It are people with lived experience that are the experts, where they have a voice, and they are taking charge. And I think we're seeing that in societies around the world. And I think part of our job is to get out of the way and support them.
Okay, I got a line up here. Ross, I'll start with you at the end. Really? Okay. You look too alert there for a second. David?
I think Leslie's right that the old farts need to retire. But
I'm not very old, though.
No, I was speaking for myself, Leslie. I do want to emphasize that, I think the up-and-coming generations are most important natural resource, and that's why universities matter. I think the U.S. has a huge lesson to teach us. I was one of those skeptics about Obamacare. You compare Canada's two cornerstone pieces of legislation, it's about 14 pages. You look at the two pieces of Obamacare legislation, it's something like 972 pages, full of set-asides and pork belly deals for this jurisdiction and that special interest group. It's quite appalling. But what was in that legislation was this push to align incentives and to experiment boldly and to reset in favor of value. So I continue to believe, perhaps naively, that if we can work with government and if we are given latitude, and this is back to getting out of the way, for institutions and LHINs and others to experiment, that we can change incentives. And I do think this is not just about culture, though culture matters a huge amount. It's also about incentives. If you look at what happened in the US, and Peter can speak to this brilliantly because I've heard him do it, it is a staggering shift in very short order in all the right directions in a system that I never thought would change, right? It was like the red-green show. I'm the US healthcare system and I can change if I have to, I guess. No, not likely. It's amazing. So I do think it's going to be multimodal, and I think incentives and government leadership is going to be important.
All right. On that theme of getting out of the way, why don't I turn it over to the audience for questions for a second. We've got some people in white who have microphones as well, so if you've got a question, let me know. And this is a very Canadian audience. In my sense. Great, thank you. In the back.
Anyway, I think I can project my voice. Thank you very much. I think, David, it was just appalling to hear that it's been going on for 40 years. I thought it was only for the last 20 years since I finished off med school. But anyway, I think what would be helpful is to understand more clearly why, what is going on in Canada that we can't get our act together. Because I don't think anybody said anything about that. And, I think Leslee tried to, but I don't think anybody said why in Canada the politicians or whoever it is that runs the damn thing haven't been able to align it. And without understanding the root causes, I'm sorry, we're going to be another 40 years before we figure it out.
Great. Thanks, Kareem. Anyone want to take a shot at that one?
I could go really dark. No.
André, you've talked about this.
I think a lot of it is about what I said before. It's the environment. We haven't created an environment that says we have to change. A lot of things, when change happens, it's usually crisis-driven, for better or worse. We don't do that. And the other part of the problem is what you heard earlier is that the vast majority of people are happy with their care. We deliver tremendous care, but we deliver it despite the system, not because of the system. We deliver it at too great a cost, and nobody's accountable for that. We're a wealthy, fat cat society, and we're spoiled, and we can get away with doing stuff that's not very efficient. And that's the reality, and we're lazy about it. But at a certain point, it's going to catch up with us, and there's going to be a crisis. And unfortunately, it shouldn't have to come to that, but I think it probably will.
All right, I'll work my way on. Susan, you're next.
One thing I would say, it's not from lack of money, and I was re-looking at David's report. The federal government's put tons of money into innovation, but if you look at primary care, which I know very well, lots of money, but the models that were brought forward over, say 15 years were not really very disruptive or innovative. They were very, kind of small changes. We've got team-based care. We've got some shifts in the way we're funding physicians. But, I don't really feel they went far enough for the money that was invested in it.
Great. Peter?
Well, one of the things that we have touched on, but perhaps insufficiently, are the social and behavioral determinants of health, health of the population. And, when I witnessed change occurring in the U.S., probably the biggest epiphany I had was when I walked into a patient-centered medical home. Many people here in the room know what that is. You walk in the first office that you see is the social worker. Across from that is the behavioral health psychologist. And they are front and center part of the team. And that PCMH has incentives in place to invest in those resources. Right now, there are no actors in the system that have the resources or the incentives to make that kind of investment. And absent those types of providers on the team and engagement of other licensed providers who are all part of the system but not contributing. And we were talking about retail pharmacists just as one example of a health professional that's not integrated into the system. And there are many, many others. We have a lot of change that we need to engineer.
Thanks. David? Okay. Last quick question right there.
Dr. Naylor, if you had the opportunity to make 2 changes to the healthcare delivery system, what would you do?
I would move very quickly to assemble the budgetary envelopes and create multiple integrated delivery systems. Probably single ones for more remote or geographically contained regions with a single budgeting entity, and I would, for a place like Toronto, might have 2 or 3 competing integrated delivery systems. Until we integrate budgets and governance, we are not going to move out of the gridlock. And that is the single fatal flaw in the Canadian healthcare system. It's a huge impediment to a population health focus. It is the Rosetta Stone. That's the overwhelming thing. The second thing that I think flows with that is to change the information systems, including making sure patients have complete access to their own records. It's appalling that we pay taxes to generate records, and then we can't even get our hands on them, right? We have to pay a fee to go get a CD that we can't read with a CAT scan on it in the hospital, waiting in the radiology section. I think we have to change the way we handle health information. It needs to be opened up with patient portals. We need a seamless system. We need to have providers connected on those systems. And the model here would be Kaiser or Intermountain again, where integration is being abetted by and partly dependent upon a complete change in the information systems, which in turn enables virtual care and keeping people out of hospitals and respecting their autonomy, especially for those of us getting a little older, respecting their autonomy by letting them age in place. Those are 2 critical changes, because with them, immediately you get a culture change. It's not about the provider anymore. It's about the patient and his or her family, and it's about keeping a population healthy to keep costs down and people happy.
Great, thanks. With that, I'm going to ask Dr. Howard Hu to come back up and thank the panelists and close off the evening for us.
Thank you, Steny. This has been really a remarkable evening, and I think part of the discussion highlighted how we have been talking initially about healthcare systems and then about health systems, and then eventually we're getting to systems for health, because in fact the players that have to be involved go far beyond just even the healthcare system or public health schools and disciplines, but in fact we will be touching on urban design, transportation, computer science, economics, even agriculture to address things like food deserts and the health disparities agenda. We have had a remarkable evening. It's just the beginning of the Dean's Leadership Lecture Series, and I'd like to thank the panelists, Dr. Naylor, Dr. Brown, for their incredible persistence and their insights. This is just the beginning of the Dean's Leadership Lecture Series, and one of the great advantages of being a young school of public health is that we get to create initiatives that are not bound by historical legacies of centers and institutes, but rather can provide cohesion in how we see the development of initiatives that can get at social innovation as well as technical innovation. In the coming months, we'll be developing leadership lecture series in some of the other areas where we are developing initiatives, things that touch on the very issues you heard today, our Big Data for Population Health initiative, some of our global health and comparative health systems initiatives that get at the concept that in fact so much of the innovation is happening not only just south of the border, but in totally other countries which have much fewer resources, but actually have addressed the innovation agenda in a totally different way. We'll be getting at some of our Healthy Cities initiatives, which touches upon one of the big themes that the new president, Merrick Gertler, has launched, as a major initiative for the entire university. And finally, our new Wakapee Nest Bryce Institute for Indigenous Health will be hosting some of our Indigenous health conversations. It's the first endowed institute of its kind to address what is arguably Canada's great health shame, which is the health of our Indigenous populations here. So thank you again for coming to our first Leadership Lecture Series. Again, thank you to our panelists and Dr. Naylor, and we'll see you again.